This is Dr. Chad Rappaport. This presentation is on current concepts regarding the treatment of osteochondral defects of the talus. This is a summary of the current literature from journals like Foot and Ankle Orthopedics, Foot and Ankle International, Techniques in Foot and Ankle Surgery, Journal of Foot and Ankle Surgery, etc. This is just a review, if you will, or a compendium of the research, the more recent research that I found when I sought out to brush up on all things new considering OCDs of the talus. I did lean fairly heavily, with the aforementioned being said, on a current concepts review article out of Foot and Ankle Orthopedics in 2018 that was done by Mark Easley's group down at Duke. I intend to cover a brief introduction into OCDs of the talus, the pathophysiology, evaluation/diagnosis, imaging and staging, treatment, and then some final thoughts. As you know, by definition, osteochondral lesions of the talus are lesions of the articular cartilage of the talus with or without subchondral bone involvement. They encompass a wide variety of pathologies with wide spectrum of treatments, and one has to remember that some of them require no treatment at all. Trauma is the most common etiology, and they remain challenging for many reasons, none the least of which is the known limited healing potential of articular cartilage and the relatively poor blood supply of the talus. Currently, there are no solid consensus guidelines with specific regards to treating osteochondral lesions of the talus, but we do know that operative treatment is indicated in symptomatic lesions failing anywhere from 3 to 6 months of non-operative treatment and displaced lesions of any chronicity. With regards to treatment, operative treatment anyways, we're typically categorizing the treatment into 3 groups, which would be repair, replacement, and regeneration. Osteochondral lesions of the talus encompass a wide spectrum, and therefore the pathophysiology is not singular. Osteochondritis dissecans is a focal idiopathic lesion of the subchondral bone with risk of instability and disruption of the adjacent cartilage. It's thought that dysfunction of subchondral bone is thought to be vascular in nature, with osteonecrosis of the subchondral bone causing overlying cartilage damage. The ankle is the third most common joint to be affected by osteochondritis dissecans after the knee and the elbow. Osteochondral lesions of the talus include osteochondral defects and frank osteochondral fractures, which are, of course, secondary to trauma. And the literature has told us that up to 50% of ankle sprains and 75% of ankle fractures entail some degree of cartilage damage. We also know from the literature that 95% of the traumatic lesions are lateral, and 60% of the medial lesions are traumatic. So it calls into question what I was taught as a student. Some may remember the mnemonic Dial-a-Pimp, which helped us remember which lesions occurred in what areas of the talus. The more recent literature supports the fact that most of these lesions are central in nature, both medial and laterally, with less being, frankly, anterior or posterior. We also have garnered from the literature that medial lesions are often deeper and associated with more subchondral changes, and these more often than not are non-traumatic. Of course, the talus is particularly vulnerable with regards to osteochondral lesions, as it is covered in terms of its surface area with more than 60% cartilage, which we know has a poor regenerative capacity. The cartilage relies on the synovial fluid and the subchondral bone, but we know that the talar bone is poorly perfused due to the limited area of the bone that's not covered by cartilage for perforators. The blood supply to the talus is through a complex anastomotic network, including the perineal, posterior tibial, and anterior tibial arteries. Historically, we have known the blood supply to be retrograde in the talar dome and talar body. However, there is some recent literature that seems to debate or question that. Another factor leaving the talus relatively vulnerable is simply the thickness of the cartilage, which is thin, comparatively speaking, to the hip and the knee. In some instances, the cartilage thickness in the knee could be twice as thick as in the talus. The presentation of an osteochondral lesion of the talus can vary widely and can be multifactorial. Patients may often complain of pain, swelling, and stiffness, but this is relatively nonspecific with regards to OCDs. Most patients, however, do have mechanical symptoms, which would include catching, clicking, locking, popping, and the sort. These are much less common than the same lesion in the knee, where mechanical symptoms are much more prevalent and frequent. There should be a high index of clinical suspicion when evaluating patients for osteochondral lesions, but we must keep in mind that not all osteochondral lesions are symptomatic, and therefore not all of them need treatment. I'm sure we've all ordered MRIs of the ankle previously, looking for perhaps a perineal tendon tear or a ligamentous injury, and the MRI will come back positive for an osteochondral lesion. And after speaking with the patient, examining the patient, perhaps giving them a diagnostic injection, we come to find relatively confidently that the osteochondral lesion on the MRI is asymptomatic and does not need to be treated. And this is why it becomes exceedingly important to take a thorough history from the patient. We don't want to treat lesions that are non-progressive and asymptomatic just because a patient states they have pain in the ankle and an MRI suggests they have a lesion. So cross all your T's and dot all your I's. Of course, we want to perform a good detailed physical exam as well and note whether there's any effusion, where the ankle is tender, is there decreased range of motion, is there laxity. Prototypically, in the office setting, we'll garner x-rays of the ankle, but historically, to be comprehensive, we will order advanced imaging studies like MRI and CT scan. I listed the technesium 99 bone scan here because of historical reasons. I don't personally use it, and I don't think many modern practitioners rely on it too heavily. As far as imaging classification and staging, I think most of us historically are familiar with the Burton-Hardy classification, which is based on plain radiographs. There are other staging systems that are either based on arthroscopic findings or MRI findings. Rich Ferkel in 1990 came out and published this CT guided staging system. All of these imaging modalities have their individual pros and cons. Most commonly, of course, in the office, we will start out with a plain radiograph, and if there is an index of suspicion and the radiographs are negative, we'll move on to an MRI, which is the most sensitive of the imaging modalities with a sensitivity of about 95%. Of course, the pros are excellent visualization of the cartilage and, to a slightly lesser degree, the bone. Cons are that it typically will overestimate the size and the extent of the subchondral pathology. On the other hand, CT scan is better at visualizing the extent of subchondral damage and quantifying the specific dimensions and locations of subchondral cysts, and therefore it's likely superior to MRI with regards to surgical planning, and therefore it's been postulated that if you have positive plain films, bypass the MRI and go for the CT scan. I prefer to obtain both, and I explain to the patient why. Arthroscopy is likely better than both, but most patients and insurance companies do not like diagnostic arthroscopies. Treatment really depends on the grade and the severity, the chronicity, and the associated symptoms with the lesion. Again, don't treat red herrings, which there are many. Be careful to take an exacting history and physical exam. Use imaging as need be, and sometimes, and often in my practice personally, I employ diagnostic injections. Generally speaking, asymptomatic lesions are generally followed with serial imaging studies, no more. And we treat lesions that are symptomatic or ones that were quiescent and have become symptomatic. Acute non-displaced symptomatic lesions can be treated conservatively initially. This typically employs 6 weeks of immobilization and protected weight bearing in a cam walker with a slow progression to return to activity. This works about 50% of the time. Acute lesions with displaced fragments are indications for surgery, as of course these will not do well if treated non-operatively. Surgical treatment involves either repair, regeneration, or replacement. As far as repair is concerned, we're talking primarily about microfracture and retrograde drilling. Bone marrow stimulation is the perforation of subchondral bone with the infiltration of bone marrow progenitor cells. These infiltrating cells stimulate repair with fibrocartilage, as we know, not hyaline cartilage. The fibrocartilage is primarily composed of type 1 cartilage, whereas hyaline cartilage is primarily composed of type 2 cartilage. Depending on what you read, the success is anywhere from 65 to 90% of lesions that are amenable to bone marrow stimulation. Bone marrow stimulation is typically done arthroscopically with the use of a thigh holder, a pump, a non-invasive distractor to increase the working space below the tibia. It's typically done through the typical anterior medial and anterior lateral portals, occasionally with an accessory posterior lateral portal. Prognostic indicators seem to include patient age, chronicity, location, containment, and the presence or absence of cystic changes, although I think this is less debatable. Osteochondral lesion size has always been something that we look at with regards to prognostic indicators following microfracture, with an inverse relationship between size and outcome, wherein the general cutoff has been around 15 millimeters. But for those lesions about 15 millimeters or less, which are contained and have good subchondral bone, this has been deemed the gold standard for quite some time. I prepared this presentation about 1.5 or 2 years ago, and there is now in the literature some debate as to whether this should continue to be the gold standard for these lesions compared to regenerative techniques. Just a quick note about distraction. Of course, working on these lesions requires that you be under the tibia, and so you want true axial distraction in these cases with the use of usually a non-invasive ankle distractor, but as you can see here on the right, far right, there's a picture of an invasive distractor. I always use a non-invasive ankle distractor for all my arthroscopies, but for most of my cases where I'm working in the anterior margin of the joint, the distractor is really there just to kind of stabilize the foot and the ankle and prevent it from moving around too much. I'm really not applying much axial pressure whatsoever, but when you need to work under the tibia, that's when you really want to employ aggressive but safe axial distraction. Older lesions, both with regards to chronicity and patient age, and lesions associated with ankle arthritis are less responsive to cartilage repair techniques. Certainly lesions with underlying cysts, which are verified and quantified on CT, not MRI, seem to be less responsive historically, but Amal, Saxena, and Robinson et al. In the recent literature have shown that the presence of a cyst may not be as much of a factor as once thought. Containment of the lesion with a healthy, stable peripheral rim seem to be more important in their works than the presence of a subchondral cyst. Retrograde drilling is typically indicated for lesions with subchondral cysts with intact cartilage, so it allows you to treat the pathology without disturbing the overlying healthy cartilage. Subchondroplasty would fit into this category. Again, since I made this presentation, Selene Perec and his group have shown some rather concerning results with subchondroplasty in the development of AVN, ultimately requiring total talus replacement. This is just an example of retrograde drilling, and retrograde drilling using a microvector here on the right side, or an ACL guide. Let's move now to cartilage regeneration techniques, which would be AC, MACI, and AMIC, plus or minus orthobiologics like PRP and BMAC. ACI is often employed after unsuccessful microfracture or a lesion that's not amendable to microfracture. It's a two-stage procedure wherein hyaline cartilage is harvested from the non-articulating portion of the talus, or more commonly the knee. That cartilage is cultured to grow chondrocytes, which are typically viable for up to a year. The second stage involves the delivery of those into the OCD and kept in place with some type of a fibrin glue patch or something along those lines. It is often used in conjunction with PRP and or BMAC. And the size of the lesion is really not a factor, but require a stable, intact cartilaginous rim peripherally. So these tend to do better and require that they are constrained lesions. MACI is the second generation of AC, and it involves a matrix which replaces the periosteal patch. It's still a two-stage procedure, but it does decrease operative time and allows for more even chondrocyte distribution within the lesion than ACI, but basically has the same indications and restrictions. The most significant downsides of AC and MACI include the fact that it requires two stages and it is quite costly. AMAC uses bone marrow-derived cells from various sources, typically the iliac crest, to achieve the same results as AC and MACI, but in one setting. And it combines microfracture with BMAC or PRP delivered on a collagen scaffold. Giannini et al. Have produced several papers on the subject, which show essentially that the results are comparable to AC and MACI. So now that we've covered restorative or regenerative techniques, we'll talk about replacement techniques, and these would be subdivided into OATS, osteochondral allografts, particulated juvenile cartilage allograft transplantation. And these are generally used for large and unconstrained lesions on the shoulder of the talus. The OATS procedure, or osteochondral autograft transfer, which is proprietary to Arthrex, replaces an osteochondral lesion with hyaline cartilage from the patient's talus or knee. If you're an orthopedic surgeon, of course, you can do this yourself, but if you're a podiatrist, you need an orthopedic surgeon to harvest it for you, which I've done several times with colleagues in my group. The benefit is that the grafts maintain their type 2 collagen, but as you recall previously in this lecture, there is a difference in terms of the thickness of cartilage within the knee and within the ankle, and so this needs to be taken into consideration. You don't want to leave these grafts proud, but you also don't want to leave them undersized. So the cons are donor site morbidity, potentially need for ortho if you're a pod, and because these lesions need to be placed in perpendicular to the surface of the talus, more often than not, if not always, you're going to need to perform an osteotomy. An alternative to the Oates procedure is osteochondral allograft transplantation, which is typically utilized for large uncontained lesions on the shoulders of the talus. These come in allograft plugs or bulk allograft. They come fresh or fresh frozen, harvested from human cadavers. These fresh allografts tend to be more favorable than the fresh frozen grafts. These are size matched from CT scans of the patient's lesions. The cons are reports of resorption, collapse, and non-union in the literature. The third common form of cartilage replacement is through the use of particulated juvenile cartilage allograft transplantation, which involves transplantation of fresh pieces of juvenile cartilage which contain live cells within their natural extracellular matrices. These are obtained from deceased donors, typically newborns up to 13-year-olds. The delivery is feasible through a smaller approach than an osteochondral graft, and therefore most times you can avoid an osteotomy. These are typically held in place with fibrin glue. This paper is now 8 years old, but it is still a very good paper that describes in detail the process of using the particulated juvenile cartilage. It's out of Operative Techniques in Sports Medicine from 2013 by Tompkins et al. It's worth a look. Chris Coetzee et al. Published in 2013 in FAI a study where they followed 23 patients in whom had this procedure done. The mean lesion size was 125 millimeters and the mean depth was 7 millimeters. They had similar outcomes to microfracture, AC, and MACI. However, in the end, they opined that for lesions that required any type of grafting below the lesion, they preferred structural allograft. Lastly, and in summary, I thought I would present and show the surgical algorithm from the paper I mentioned initially from Easley's group, which shows how they algorithmically address the lesions based on size, location, etc. This is a picture taken last year of myself down at Duke with Dr. Nunley and Dr. DiOrio. And spending time with guys like this that really inspire me to get better and to read, which is what I tell my residents when they ask me to give them one piece of advice. Thanks for watching.